Hello, everybody. I am Dr. G.N Ramesh. I am a medical gastroenterologist and a lead consultant in medical gastroenterology at Aster Medcity Kochi. Usually, you will find that patients with gastroesophageal reflux disease complain of classic symptoms. The classic symptoms are heartburn, retrosternal discomfort, and regurgitation. So if the symptoms are classic, the first step would probably be a trial of therapy with proton pump inhibitors, which should be not less than 8 weeks in duration. Ideally, the PPIs are given as twice daily, half an hour to 1 hour before food. If a patient responds well, by 8 weeks, the response should be approximately 70 to 100%. If that be the situation, after 8 weeks, you could either continue it or taper down the dose of PPIs to what we call as the minimum effective dose. If that is not possible, or if the patient develops additional symptoms, then we need to do an endoscopy. If the patient does not respond to what we call as a trial of proton pump inhibitors, that is also an indication for endoscopy, because I would like to know why this patient is not responding to proton pump inhibitors. And then if the endoscopy shows features of reflux esophagitis, a diagnosis is made. If the endoscopy does not show any features of reflux esophagitis, that would be a segment of patients who would be candidates for pH monitoring. That will come much later. So therefore, if my patient with a classic or classical presentation of reflux does not respond to PPIs, or if there are some atypical features, or I am not able to taper the medicines beyond 8 weeks, these are patients who would then be labeled as refractory GERD. So what would be a good algorithm to follow for patients with a refractory GERD? For classical GERD, I did mention it is quite simple. It is not all that complicated. But for refractory GERD, let us take a situation where a 45-year-old lady comes with symptoms of heartburn and reflux, has been put on PPIs. After 2 to 3 weeks, she fails to improve. She comes back. You also add on some antacid at night. After 2 weeks, she comes back with symptoms. That is called refractory GERD. Now, the first question to ask is whether this patient has got any alarm symptoms. By alarm symptoms, I mean any one of the following: dysphagia, weight loss, anemia, severe pain on swallowing, which you call as odynophagia, then GI blood loss. All these are alarm symptoms. Also note that if the patient has got a strong family history of gastrointestinal cancer, that should also be considered an indication for early intervention or early investigations. So if this patient has got any one of the alarm symptoms, also a nocturnal cough, breathlessness, severe laryngitis, all these are alarm symptoms or signs. The next best step to do would be an upper GI endoscopy. In the upper GI endoscopy, I'm looking at whether this patient has got any features of mucosal damage in the form of esophagitis. Does this patient has got any features of inflammation in the upper esophagus or even the vocal cords or the arytenoids, which would tell me that this patient does have features of reflux? Or does this patient has any peptic stricture, which is an advanced complication of gastroesophageal reflux disease? Now, if the endoscopy has been done and shows features of reflux, esophagitis, uncomplicated, or even sometimes many a times with severe symptoms or refractory symptoms, you find that the endoscopy is normal. The next question to ask is, has my patient been taking PPIs optimally? Has my patient been following the advice as far as lifestyle modification is concerned or adherence? And have we gone to the other steps of splitting the PPI dose, trying a nocturnal dose, or changing from one PPI to another? If it is rabeprazole, have I tried pantoprazole? If it is esomeprazole, have I tried rabeprazole? If nothing is working, have I actually tried omeprazole? Because nowadays we have a tendency to put omeprazole into the waste paper basket because we have rabeprazole available or pantoprazole available. Now, if we are sure that the PPIs have been tried optimally, I think we should give it one more chance, double the PPI dose. So if the patient has been on pantoprazole 40 milligrams once daily, increase it to 40 milligrams twice daily. If the patient has been on esomeprazole 40 milligrams once daily, increase it to 40 milligrams twice daily. Sometimes it may work and there is a good resolution. And then after giving this particular regime for about 8 weeks, taper down to the lowest dose that controls the patient's symptoms. So 2 things I think I would like you to always bear in mind. Escalate to the maximum tolerated dose to induce remission of symptoms, and that should be done fast. And then once the symptoms are under control, try to achieve the minimal effective dose, which may vary from patient to patient. Now, even if the double dose PPI does not work, then I think it's important that we look at the upper GI endoscopy once again and take biopsies. Why biopsies? Because it has been shown that the rare patient or the odd patient with eosinophilic esophagitis can present in this manner. So it is important that we do biopsies along with the endoscopies.